You could help support the One Thing podcast by visiting our affiliate sponsors. I've teamed up with Healthgevity, which is a company that I learned of over the last several years. I really enjoy what Healthgevity is doing. They've revolutionized the wellness industry by providing the finest quality and most effective nutritional products for ultimate health span. They work in tandem with doctors, patients, and researchers to design real advanced formulas that, frankly, I have not seen done on this level before. Please visit them and see what they have to offer. If you find various products that you're interested and you're looking for a discount, you can enter in the code ONETHING, all one word, one thing, for a 10% discount. This will not only provide you access to excellent health supplementation products, but also will help support the podcast. Thank you so much, and I appreciate your support. Hello, everybody. This is Dr. Adam Rinde, and welcome back to the One Thing podcast. I'm delighted to be here with you again. In this episode, I welcome back Dr. Carla Kuon from the University of California, San Francisco. She has been with us before on previous episodes. She's back to talk to us about updates related to post-viral syndromes, including long COVID. Also, information related to people she's treating who are dealing with chronic fatigue syndrome and fibromyalgia. Dr. Kuon is the author of a book called The Long COVID Solution. She's taken her experience working with post-viral syndromes and really being able to help people with long COVID. And she heads up the program that's addressing long COVID and complex viral illnesses down at the University of California, San Francisco. In this updated episode, Dr. Kuon will share much information about research that's going on at University of California, San Francisco to address viral persistence. And she discussed her pivot to addressing mitochondrial health and specifically what she's learned about riboflavin and iron in the care of her patients. We met several years ago as part of the Cogence Immunology course, and what I've always appreciated about Dr. Kuon is she's very holistic and integrative in her approach, and she really likes to learn mechanisms and pathophysiology and dive deeply into what's actually really going on. Instead of just focusing on medicines and treatments, she's really trying to understand how to best support her patients, and her care really shines through when you listen to her talk and how much she truly cares about practicing medicine the right way. So I hope you enjoy this episode as much as I do. I think it offers hope and new suggestions and sheds light on the evolving landscape of addressing chronic persistent infections. So without further ado, welcome to the next episode of the One Thing podcast. Dr. Kuon, welcome back to the One Thing podcast. It's so great to be here with you again.
Thank you, Adam. Thanks for having me again.
You're welcome. It's great catching up, and I know we've kept in touch over the last few years, and I really appreciate being connected to you and just knowing that you're there. It's been very comforting and supportive, so thank you for keeping in touch.
For me as well. I think, those of us who are on the front lines doing the hard work, working with all the fatigue syndromes, we need to support each other.
Exactly, yeah. Well, I thought a great place to start would be to discuss where we're at today with the post-viral syndrome world, long COVID world, ME/CFS world. Are some of the questions that you had, say, 2 or 3 years ago starting to be answered or starting to be solved?
Yeah, I think that it has been such a whirlwind learning tour over the last couple of years. Number one, I think confirming many of the things that I had observed in the fatigue world, but also shedding new light on new pathways. Some of the things that I've learned in the last couple of years is just how much, and you and I talked about this, just how much long COVID causes endothelial dysfunction and microclots. We had seen some cases of COVID blue toe, and at first nobody had any idea what was happening. And there were a few cases of blood clots, but it definitely was not one of the more common presentations. But now there's more evidence that even in people who don't have blue toe or large clots, that there's evidence of microclotting and endothelial dysfunction. And just, this is probably your experience too, but the amount of patients that have abnormal markers in the workup, the D dimers, the fibrinogen, the vasculoendothelial growth factor, once I started uniformly ordering those in all of my patients, I was kind of astounded how often that comes back as abnormal. And so it's definitely a much bigger prevalence than I had anticipated previously. And the other things that are unfolding as being huge too is, the amount of dysautonomia that is present in people with long COVID. And I suspect chronic fatigue as well. I think that chronic fatigue, myalgic encephalitis is the older cousin of long COVID, different pathogen, very similar, biology and pathophysiology. I like to call the grouping long COVID and its ugly cousins, and you can add Lyme, EBV, mold, methanogens, gut pathogens, candida, reactivated EBV to those, right? Because everybody has EBV, but for people who are reactivated, and then EBV is problematic for those. And the amount of dysautonomia, not all viruses cause it, but the ones I think that do cause long COVID or CFS maybe have that in common, that they do really impact the brain and really rearrange the brain, or the way I like to describe it, like implant a bad program in the brain so that it's not able to function at the same level before. It's almost like they download a new program into the operating system of the brain, and it's not really able to work the same way that your computer might not work well if you upload a bad program into it. And I think that's something that we did not really know that much before about, and we're starting to study it more. The fight or flight that never turns off, the hyperarousal, the insomnia. If COVID gives us any kind of a gift, it is to add to that knowledge and help us understand the importance of this better.
Yeah. So has the map view, like the big view, if you're looking down on a map of strategies and the core elements of where we start with these cases, has that shifted around a bit?
When I wrote the book and I had my 4 buckets of fatigue, if you recall, we talked about inflammation being the biggest bucket. We talked about toxins being a huge bucket. We talked about nutrient deficits, and that's where mitochondria comes in, is a big bucket. And we talked about physiologic stress, right? So the buckets are actually all the same. We're just getting more information about the actual mechanisms in those buckets, right? So under stress, I now talk a lot more about dysautonomia. And I was talking before about the vagus and POTS, but I just emphasize it a lot more because before it was a theory, and now there's so much evidence to prove, the nitty gritty details of how that works, that I was actually aware when I wrote the book in 2022 that it may be outdated in a year, after we get so much new data on long COVID. But I've been surprised at how all the core principles that I discussed are really standing the test of time. We just kind of have new terminology and new things that we talk, that explain those concepts maybe in a slightly different light or a different angle. So I think all of the core principles that you and I learned in the Cogent's immunology program are the same. We just are saying different words or calling it different terms, and the sophistication around the dialogue we're having is more knowledgeable, and we're being more specific about how we talk about those buckets, but that the concepts were solid enough that they're all the same.
Yeah, it's really interesting, the dysautonomia piece, because this sort of is a great way to see why people persist with this illness, because if the dysregulation of the nervous system mirrors the dysregulation of the immune system, and we have this scenario where their function has just become unstable in those two areas, as far as being able to resolve these illnesses and move forward or restore health. Can you comment on that a little bit?
Yeah. So, those of us who read a lot about functional medicine, integrative medicine, there was a term that was coined a couple of decades back, which was the cell danger response, right? And cell danger response in the brain is dysautonomia, right? So the brain is still responding like the body is under attack and it's in fight or flight mode. And I think of the brain as an operating system, but that it's a living, breathing, organic operating system instead of a machine operating system. And what these viruses or pathogens do in, spirochete and the world of Lyme is we know now with COVID that up to 10% of patients have a little bit of viral persistence. And so there's no live virus probably in the body, but there's proteins that may have been embedded within cells. And when cells try to cleanse themselves and, get rid of them, they go back out in circulation. And now the immune system is very trained to react to it. And so the body stays in this persistent hyperarousal, flu-like state. And that's one of the mechanisms. But also our brain is a learning organ, right? And if it learns to be in fight or flight for a long time and it doesn't have a really good way to reset itself, then it may stay in this fight or flight state for a long time. The way I like to explain it to my patients is I think everybody's had this experience where you download a new program or a new app and all of a sudden Word doesn't work, Microsoft doesn't work, and everything freezes. And even after you realize this is a bad program and you delete it, your computer may not work well until you do a reboot, right, of the computer. So how do people reboot their brains? We don't, right? It's still working even when we're sleeping. It's helping us breathe and it's helping our heart keep going. So your autonomic nervous system never has a chance to reboot after that. And so if you don't know how to reboot your brain by adopting mindfulness or, vagal techniques, then your brain will always operate as it was when you had a fever and you had COVID, and it just recycles that information over and over again. And so I think we're entering an age where we're going to learn a lot more about this and have a lot more acknowledgement of the importance of this. I think I work in an integrative center where we've been researching mindfulness for years. And I think a lot of people say, okay, yeah, that's great, but it's not for me. And I do think it's going to become much more important in the future.
You just brought a smile to my face because I think I might have mentioned this last time we talked, but like the first integrative medicine course I ever took was through the OSHER back in 1998 or so. And things were really basic back then, but biofeedback and breathing techniques, not a whole lot in the course, but that was where it all started. And then over the bridge there, I think you also have a lot of, in Marin County, there's a lot of integrative research going on as well. And that's been such a big part of the growth of the field. So I really like what you said earlier about, just as far as, I don't like it, but I like the clarity. I don't like this for anyone to be dealing with this, but the clarity of the body's kind of wired for danger right now in these scenarios and is living in danger mode. And that's really a great way to see what's going on with the nervous system and how we would begin the quest to unwind that and restore health. So one of the things that we talked about through some of our discussions was mitochondrial health. And I would really like to hear where the path has led you in understanding what's going on with the mitochondria in your patients.
Yeah, so it really came from my patients' questions. As you may or may not know, I lead a long COVID group medical visit. After I wrote the book, I was asked to become director of the long COVID clinic at UCSF, which we call the Optimal Clinic. And at the time this happened, I received about 300 or so referrals, and they were all on this wait list. What I did is I devised these group medical visits where I see 10 patients at the same time, 10 long COVID complex patients at the same time. And I had to devise a little bit of protocol so that, I could keep the mill running really at a fast pace. And I based handouts and I gave them all handouts because, brain fog is real. So I wanted them to have material they could go over back again if they had forgotten. And the material included all of these nutraceuticals like, riboflavin, glutathione, iron, et cetera. And during our Q&A, patients, because they're going online and they're doing their own research on fatigue, they kept asking me, well, what about the mitochondria? Can I take CoQ10? And I realized, okay, I need to go back to my handouts and reframe a lot of what I'm saying around the kinds of things that patients want to hear. So all of the nutrients, I would go back and explain to them, yeah, these are the nutrients for your mitochondria, so that I was being informed by my patients. How do I present this information to you? And everybody hears about mitochondria and is interested in it. So I started looking a lot more closely into the nutrients that help the mitochondria work well. And to my surprise, CoQ10 is not the most important one. And I started screening my patients for riboflavin deficiency. And riboflavin ended up being a gold mine for me. It's changed so much of my practice because I started noticing that a lot of people's riboflavins were below 5. So they were flagging in the red, or they were borderline. And a lot of people become symptomatic when it's borderline. And then I started looking into riboflavin and mitochondrial health. And I feel like riboflavin, if I want to highlight one vitamin that is like my hero of the year or of the decade, it's riboflavin B2. It is the little David to the Goliath. It's the little vitamin that nobody talks about, nobody cares about, nobody checks, and it is a rock star. It is so important. The more I look, the more I see riboflavin is everywhere in fatigue and mast cell activation and all of the things that cause CFS and long COVID. And if you look at the literature, it makes it sound like it's a rare deficiency. If you look at your supplements, they have the minimal amounts of riboflavin. They'll give you all the other Bs, but not riboflavin. So it is a real gold mine, very ignored. And frequently people have riboflavin deficiency and fatigue syndromes. So riboflavin is my number one rock star. And I don't give it to everyone, but I screen for riboflavin deficiency and those who are low in it. Then I know a lot about their physiology because riboflavin is everywhere in the mitochondria. And more importantly, it's everywhere in the citric acid cycle, which is the first part of energy metabolism that fuels the mitochondria. It's important in the L-carnitine shuttle, which shuttles fats into the mitochondria. It's important in the liver to break down histamine to support aldehyde dehydrogenase, and it recycles glutathione. So it does so much. Many people have had their B12 checked, but never their B2. So that's super interesting. And I learned that riboflavin is also associated with MTHFR variants. So when you see a patient who has riboflavin deficiency, all of a sudden you know their mitochondria isn't working, their citric acid cycle isn't working, their liver is not clearing histamine through ALDH, and they're probably under methylators, so they don't clear toxins really well. And it's just like, gave me such a wealth of information. All the things that you and I see in fatigue came down to riboflavin. So that's like my hero of the year, that one. And then, iron, I screen all my patients for iron deficiency, and intracellular iron, which is ferritin, is also all over the citric acid cycle in the mitochondria and in the liver to clear histamine. So these two guys have really changed my practice.
Wow, that's really good information. And I want to dive into some of those pathways a little bit more, but sort of more of a bigger picture question. Why would a person have riboflavin deficiency? Is it a intake absorption issue? Is it a polymorphism, like a genetic issue? Is it that it's being used up a lot because of these conditions? What are you thinking on there?
Yeah, that's a great question. So there's a couple of factors. The first is yes, it's associated with MTHFR methylation. So people who have MTHFR variants are susceptible to riboflavin deficiency. But number two, and I think people with MTHFR or other methylation variants in general are more dependent on all the B vitamins, folate, B6, B12, right? So they have a greater need than they can get through diet alone. But the difference between all the other Bs and riboflavin is that our liver is able to store B12, B6, zinc, and many of the other Bs, but we don't really have a good way to hold on to riboflavin. And so if you can't store it and you take a riboflavin and you eliminate it through the urine and it's gone from your body the next day, then there's not going to be any way for you to ever get enough from the diet because you don't have a storage mechanism. So let's say you eat a real riboflavin rich meal one day, it doesn't carry on to the next day. You're low again the next day. So for that reason, riboflavin is a great way to screen for methylation defects because it is the one vitamin that we need large amounts of every day. And I feel like our foods are not really fortified with riboflavin. They're fortified with B12 and folate universally, but there's no government mandate to fortify foods with riboflavin. So very hard to get it from diet alone.
I've always thought that the best source for it is like liver and organ meats and whey, eggs, those types of foods that not many people are eating organ meats. Some people are, but in some cultures and parts of the world. But I mean, liver is, sort of what grandma used to eat. And, nobody's really running to get first in line for their liver. So, yeah, it seems like I would see it fortified in a lot of cereals and products like that. But as you're saying, maybe it's the fortification levels just aren't enough.
That's right. When you look at the B complex, so like you'll see B12 and you see that the percentage is like 5,000, the RDA. But look at the content of B2 and you'll see that it's maybe like 200% the RDA. So it tends to not really be emphasized in a lot of supplements and probably not in fortified foods either.
Interesting. That's fascinating that we don't have a storage tissue or storage organ for it. So the other comment you made was about iron, and that's fascinating to me as well because you talked about ferritin and the difference between iron and ferritin. And some people wonder about why their ferritin is low. And some people, we always have like red flags when we see low ferritin that people need to look for like blood loss and, especially through the digestive tract or excessive menstrual bleeding. And there's some common causes for low ferritin. But in the chronic fatigue world, what are you seeing and why would someone have normal iron but low ferritin?
That is an excellent question. Normally, when primary care doctors get an iron panel, they're going to get serum iron and maybe, total TIBC, right? Iron binding capacity. But that only measures the iron in your blood. Ferritin is a much better marker of intracellular iron. And women are at high risk due to 30, 40 decades of their life of menstrual losses. But men with gut issues like IBD or IBS may also be at risk for iron deficiency because they're not absorbing. Although I did see one gentleman who had perfectly good gut health who was an athlete, and he had really low ferritin. And what I've discovered is that when you have inflammation, your body upregulates hepcidin, and hepcidin upregulation means you don't absorb iron. And people who exercise a lot are always a little chronically inflamed. It's a, it's a good kind of inflammation, but it does prevent iron absorption. So I had this guy do a colonoscopy and everything. It was really fine. And then I had to dig around. I was like, oh, like he was a world-class athlete. So he was always exercising and he was not absorbing iron. And then he got long COVID and he couldn't exercise at all. So it's really interesting because most of the people we see with fatigue are inflamed. And so ferritin will go down because they're no longer absorbing it from the diet. But if you are a fertile woman, it may have been low to begin with, and now it's even lower. I want to maybe just show you the mitochondria here so that you can see. So this is going back to high school, right? The Kreb cycle. Everybody fell asleep probably during that class. So generally, we get energy from fats, carbs, and proteins. And you see here how riboflavin is important in breaking down fats into beta oxidation. And you see how riboflavin B2 is also important in breaking down carbs. And then that gets fed into the citric acid cycle. And here's iron, and there's glutathione, iron, glutathione, B3, which is niacin, and magnesium. Magnesium is also important in fats. Here's again B2, magnesium, iron B2, and B3. So B2, B3, magnesium, and glutathione end up being the really, really important pre-mitochondrial nutrients that nourish the mitochondria. And then there's this backdoor that shuttles fats directly into the electron transport chain, which is the L-carnitine shuttle. And that one is also riboflavin dependent. So if your riboflavin is low, you can't get the nutrients or precursors into the mitochondria. And look at CoQ10. It's like only at the mitochondrial membrane, but there's like all of this stuff that has to happen before to feed your mitochondria. So I thought that was really interesting.
Really is.
So if you're a woman and you have low iron and low B2, your mitochondria is at a complete standstill.
And that has other implications that we see. Obviously, you see I've always thought about iron being so involved with oxygen, transfer of oxygen into tissue. And I'm also hearing some things in this world about its low iron's impact on sleep disruption. We see it affecting restless legs. People who have low iron seem to be at high risk for restless leg syndrome. But it just seems like, hypoxia issues, we're just getting to know what they mean, really. In a clinical setting, there's been tons of research on it, obviously, but to see it stand out clinically, those patterns are just really starting to show, at least in my world. What do you think about that?
I absolutely second everything that you said. In fact, I think the Mayo Clinic has done some really fancy testing for people with chronic fatigue syndrome. And of course, I hear it from my patients, so I learn a lot from them. And they said, oh, I went to the Mayo Clinic and they did this MRI exercise tolerance test and told me that I have preload failure. And there's this paper published that preload failure is common in chronic fatigue syndromes. But guess what else can cause preload failure is low ferritin. And then, your heart is having to pump faster because it's trying to compensate for the low oxygen state and it has to accelerate. And so now you have strain on your heart and your brain, which is a very oxygen hungry organ, is not getting oxygenated well. And that contributes to the brain fog and the inattention. And exercise intolerance is a huge part of CFS, ME, and long COVID. And if you're not oxygenating well, you will easily go into anaerobic state and produce lactic acid, even if you're just, cooking and cleaning around the house, because that you will easily go into anaerobic state even with mild exertion because you can't oxygenate well. And that next day you have lactic acid and you're sore and you have all these fibromyalgia symptoms. So iron and B2 are, I think, my top two nutrients. I will give B2 if somebody's B2 deficient, but probably even more commonly I see iron deficiency, or I would say low ferritin, right? That's the more appropriate marker to get. because people with normal serum irons will still have very, very low ferritins. So ferritin is what will check for these intracellular, needs for the mitochondria and the cell.
Hmm. And do you usually send people in for infusions for some of these nutrients?
Yeah, if they're fertile and they're still losing blood through the menstrual cycle, I know that it's going to be really hard to get their iron up. So I will recommend iron infusions for those patients. And I'll usually preload them with glutathione so they can get their glutathione levels up, but also to prevent the Fenton reaction so that they don't get that sort of iron sickness that some people get. And it helps a lot to get the glutathione before.
Oh, okay. So you preload with glutathione. And I've heard that because this is such a sensitive population as far as they become very reactive, a lot of people in this world have mast cell activation issues and lots of histamine like reactions to all sorts of things. Do you have to pick a specific type of infusion, iron infusion for this population, or you just go with kind of the standard?
I go with the standard, which is ferrous gluconate. If people do react to that, sometimes I'll have them take an antihistamine before, and we might change it to one of the other formulations that are better tolerated. But it's a really minute percentage of people who react to them. I'd say more generally, people will have the Fenton reaction, and usually preloading them with glutathione takes care of that. But the true sort of like hivey, rashy type reactions happen in less than like 0.5% of people. So fortunately, I haven't had too many problems with that.
Yeah, I mean, it's really great to get these granular details about mitochondria. We hear so much about how they're the root of everything, and healthy mitochondria really relates to a healthy organism, and so if we're able to find ways to step into this pathway safely and supportively, and I imagine you have some type of time frame that you would expect for this to help. Is there sort of a expectation the patients get when they start working on their mitochondria about when they'll start to see benefit?
Yeah. So if they have riboflavin deficiency, most of the time they feel the impact right away. Riboflavin is really well absorbed.
Hmm.
And so the levels will go up very quickly and they'll get that impact right away.
Hmm.
If they have riboflavin deficiency, I'll oftentimes add L-carnitine as well, because I can predict that the L-carnitine shuttle needs a little bit of help as well. And they'll notice it the same day or the next day. So I tell them give it a week, but a lot of times the impact is immediate. Iron's a little bit harder because if you're inflamed and you're not absorbing well, and we don't absorb iron really well anyway, then it could be like a whole year before you can get their iron levels up unless you do a couple of iron infusions. So that one is kind of a long haul, no pun intended, that to like get the iron up to speed. And I normally recommend a level of 100. But even if they can get their ferritin from, say, like 10 nanograms per liter to 30, even though that's still well below 100, people feel the difference. Like every small amount of oxygenation that you can optimize, people will start noticing subtle but gentle improvements in their energy.
Definitely. Yeah, that's really great that you're able to, since you're associated with a hospital and the infusion center, that must be so convenient for your patients to be able to do that, because it does take an order from a medical doctor, and there has to be an infusion center, and it's not something generally people can just do very easily on their own. Or
Yeah, I normally can't get it through the hospital. It's not really covered for iron deficiency, unfortunately. So some of these people I will send to naturopaths so they can get it at a naturopath's office.
oh, like an IV center. Okay. Yeah, that's true. That's another option is, some integrative or functional medicine doctors will have IV clinics, the capacity to do that. So that's good. Yeah. Because the oral forms are often difficult to absorb, obviously, and then some of the forms can cause digestive distress, and most of the people in this community are already dealing with digestive issues. So that's a great option.
That's right.
So I'd love to hear a little bit about the research that you're doing at UCSF. It'd be really interesting to hear how that's evolved and what you're focusing on right now.
Yeah. So the person heading the research at UCSF is Michael Peluso, and he has a long impact of COVID study. He has been studying viral persistence patterns in patients. They published a initial study in British Medical Journal last year that showed that 1 in 10 people with long COVID will have viral persistence proteins that may be causing their long COVID symptoms. And that's really interesting because you might think that if there was a way to screen for that, those people might be the ones who respond to Paxlovid, or a COVID vaccine. And there are 2 more trials that they're analyzing the data on right now on tissues and viral persistence. There's also a new study that they're about to launch a new trial called Reverse LC, or Reverse Long COVID. And that one is using baricitinib, which is a JAK inhibitor, which is a way to lower cytokines and inflammation as well. Although, as we were talking before the podcast, could be really interesting to do one with other things like rapamycin, since you mentioned it, and we know that that is a good anti-inflammatory as well.
Definitely. We're getting to these stages of this where we're understanding more and more about the biology, the immunology, and that's really interesting that using a JAK inhibitor to target the key cytokines that are involved with like a post-viral illness. I mean, people might think, from the outside world, not really knowing much about this is like, that must seem like a really strong medication to use, but this is such a debilitating condition and we don't have words to describe what's going on, generally speaking. Like we don't have an autoimmune subtype that we could name this, but this is behaving very similar to other conditions that might fall into the autoimmune world. And because we don't have a name, this gives us a window of what it was like for people before they knew what rheumatoid arthritis was. I mean, before they knew what Crohn's or colitis was, and they were just running amok with inflammation day by day by day. So we're seeing these patterns, and it's a frontier because there's not a definition, there's not a name. And so some of these trials really help us kind of get more defined.
For sure. And, Michael Peluso is an HIV researcher who is now dedicated to researching long COVID. And it's really interesting the parallels between the HIV epidemic, where people had this new disease that nobody knew what it was, and a lot of people were dying. And it spurred a lot of research that really brought medicine to a new frontier of understanding the immune system better. And as a result of that, there's been benefits. The cancer world has benefited from the research. Researchers were going after, the golden prize of a vaccine that protected you against HIV. And even though that was never obtained, all of the research along the way have given us new immune modulating drugs that have benefited the autoimmune world and people with rheumatoid arthritis or people with cancer. And I think COVID is going to do the same for us in terms of understanding the immune, inflammatory, and central nervous system underpinnings of, the fatigue syndrome world. And so I think in the end, it will really spur the research need. And the other thing that's ironic is Paxlovid is a repurposed HIV drug, right? So there are so many parallels between HIV as a novel virus that our immune system had never seen, and COVID being this novel virus their immune system had never seen. And all of the immunological inflammation that we see. So it's really very an exciting time in research, but of course, a terrible time if you have long COVID.
Exactly. Yeah. Well, one of the things that's really stood out to me in getting to know you, I think on the first time we had a podcast together was just how well you're doing taking care of yourself. At least I remember you meditating a little bit before our first podcast. And I just really would love to hear how well you've held up through this really grueling area of specialty and holding that space for your patients. And the fact that this is a long process with every patient. How have you done it?
Before our podcast, you and I were talking about MBSR, right? And you mentioned your experience at the Osher Center. I had kind of a similar experience too. I was a burnt out physician and I was going to leave medicine. I had my exit plan already. And one of my colleagues encouraged me to take MBSR for physician burnout. And I went in feeling very skeptical, thinking, how is sitting around with other people singing Kumbaya, how is that going to change the fact that I see death and dying every day, the fact that I work 14-hour shifts, miss weekends, holidays with my family. But I went, I respected her, and she said it changed her life. And so I was there to see what they had to offer. And it did. It changed my life. I very clearly noticed once I went into a grounded, mindful state that I needed to pursue a different career. And what was really interesting is things aligned for me very quickly after that. I heard about the Osher Center. I had 1 month to apply. I gathered my application very quickly and interviewed, and I've been there ever since. So that experience imprinted in me a need for daily meditation. I have a meditative grounding practice, and I think that's what kept me, head above water during the pandemic and the stressors. And I think that it is what all of us who are frontline workers, we need a way to reset our central nervous system because of the stress of providing care for those who need hope.
That's so great to hear. And I do think, when the time is right for our patients along their journey, dipping their toes in some practice that is connected to breath or grounding or movement, regulating the nervous system is always a really great leg of the journey. It's not for everybody at certain stages, but I've found the patients that I see getting to the other side of this have somewhere along the way picked up some mindfulness based practice that works for them and their own beliefs and their own values. And it's just great to see you demonstrating that. It must be so inspiring for people.
Thank you. Yeah, I think that's also why acupuncture works really well, right? I have a lot of my long COVID patients who feel that acupuncture helped. And if you're not somebody who is going to be keen on taking up a mindful practice and you can get acupuncture, regularly, then that is a way to sort of calm the central nervous system down. And so there's a plethora of modalities and ways to do it. We talked briefly about the TVNS gadgets and devices that are out there. So there's something for every personality type. If you're more of a gadgeteer, more gadget oriented, you can get one of the TVNS devices that are out there. If you're somebody who's open to breath work and mindfulness, you can go in that route. So that's a good thing.
Yeah, so true. Yeah, the transauricular vagal stim is something that you're doing quite a bit of, right, at your center?
Yeah, I recommend that all my patients adopt a 10-minute mindfulness practice of their choice. And I usually will show them different gadgets. And I say, if you think that mindfulness is not for you, then you can get one of these gadgets. And we know that GammaCore has the most research, but it's quite expensive. Fortunately, there's a lot of new gadgets that have come out that are under $300 that most people can afford. and they can just, turn them on for 4 minutes a day and feel the benefits instantly. So that's been a real huge success as well.
I agree. Yeah. Well, this has been really delightful once again. I thought maybe we could just wrap up with just any words of inspiration or closing thoughts that you would like to share with the listeners. I thank you again for all the work you're doing and contribution and just being such a great example of how to be a true healthcare provider. So I thank you once again.
Thank you, Adam, for this wonderful podcast as well. I mean, I just think that for those people who have lost hope, I hope that they connect with other long COVID survivors who have gotten out of the tunnel and back into the light. It is absolutely possible to heal. Your body has an incredible ability to heal. Sometimes it's just knowing, where the defect is. And that's what integrative providers are there for, is to help figure out, with nutraceuticals and diet and mind-body techniques, how to find that bad program and how to help the body heal. And once you give the body a little push, a lot of times it does the own work. So it's absolutely possible to heal from long COVID. And I hope this is a podcast that will give people hope.
Excellent. Well, thanks again.
Thank you. Bye, Adam. Take care.
Thank you so much for tuning in to this week's episode of the One Thing Podcast. Please share these episodes with your friends, loved ones, colleagues, patients, healthcare providers, anyone who you feel might benefit from hearing these informative interviews. We tend to learn best from people sharing things with us. That's often the first time it's introduced. So don't hesitate if the content of these episodes reminded you of someone that might benefit from it. Forward the episode to them, and I'm sure they'll either appreciate it or be appreciative that you've thought of them. So once again, we'll look forward to seeing you next episode on the One Thing Podcast. And again, much appreciation for you being here with me.